lecture series Uveitis part 14, and in this part we are going to discuss about the bacterial uveitis, and today we are going to discuss about the Lyme's disease. Lyme disease, borreliosis like syphilis, is caused by the spider cheat. The responsible organism is Borrelia burgdorferi. It's transmitted through a tick bites, with deer being an important vector. So basically, Lyme disease is caused by an infection, spider cheat named Borrelia burgdorferi, and it is basically transmitted through a tick bite. And deer is an important vector, and adult tick can distinguish from a head louse by the tick having eight legs. It is an arachnid, and the louse has six legs. Tall larval ticks have only six legs. So basically, the tick has eight legs, whereas the lice has six legs. But sometimes the larval tick has also the six legs. The disease is endemic in the region of North America, Europe, and Asia, but can be difficult to diagnose. Several days after a bite, an annular skin lesion, erythema, chronic migraines form at the site of in 60 to 80%, often accompanied by the constitutional symptoms stage 1. So, first stage is going to be the stage 1, and in this part, erythema migraines, which is a characteristic of Lyme disease, which is like a bull's like eye like lesion on the skin is formed, and with the constitutional symptoms, which is a stage 1. Then a neurological, for example, cranial nerve palsy, meningitis, cardiac arrhythmia, and other manifestation may follow within a week. So this is stage 2. Late stage 3 complications include chronic arthritis of large joint, polyneuropathy, and encephalopathy. And stage 3 consists of arthritis, neuropathy, and encephalopathy. Some patients develop chronic symptoms that may not respond to antibiotics. So let's see figure 12.69 is showing the transmission route. So you can see the deer is an important vector, and rodents as well. So when they bite isodex ticks, bite these, and then they bite humans, they causes the infection in the human. Next is, you can see the tick is attached to the eyelid. C is showing a severe erythema, chronic migraines, like it has a characteristic pattern of a bull's eye, like it is a darker inside, then there is a less pigmentation inside, then there is a darker pigmentation. Next is, what are the ocular features of a Lyme disease? These are varied and tend to occur in established stage 2 and stage 3 late disease. Uveitis is relatively uncommon but can be anterior granulomatous or non-granulomatous. Intermediate, the most common are posterior, including multifocal choroiditis, vasculitis, and neuroretinitis. So uveitis can be anterior, intermediate, and posterior. In anterior, it can be granulomatous or non-granulomatous. Intermediate can occur, and posterior include multifocal choroiditis and vasculitis or neuroretinitis. Other manifestations include early stage 1 transient conjunctivitis, bacterial stromal keratitis, episcleritis, scleritis, orbital myositis, optic neuritis, papilledema, and oculomotor and facial nerve palsies. Up to 25% of the facial nerve palsies in the endemic areas. So other manifestation of the Lyme disease include all other features like conjunctivitis, keratitis, scleritis, myositis, neuritis, facial nerve palsy. So what are the investigations? Serology should be performed at least a month after infection, but false positive can occur. PCR of CSF or synovial fluid is performed in appropriate cases. Diagnosis relies on a combination of a clinical feature and positive serology. Co-infection with other tick-borne disease is possible. So you can also do PCR of CSF or synovial fluid, and you can see if there is an infection with it. And basically, you just do diagnosis on the clinical features and the positive serology. Next is, how do you treat the Lyme disease? Doxycycline or tetracycline is basically the major course of the treatment. Treatment of the early acute disease is highly effective and involved oral doxycycline, not children or in pregnancy, where you give erythromycin, amoxicillin, or erythromycin. Untreated, many patients with early or asymptomatic disease will experience no further problems. Patients with established disease, including ocular, may require extended intravenous penicillin or ceftriaxone. Keratitis and uveitis may need steroid treatment. Systemic steroid should not be given without a concomitant antibiotic. So you have to give antibiotic first and then you start steroids if you want to give the steroid. Appropriate personal protection clothing, insect repellent should be adopted in endemic areas to reduce the risk of tick-bite. Lyme disease vaccine is available but does not offer complete or prolonged protection. Next is the brucellosis. Brucellosis is caused by the gram-negative bacteria Brucella militensis or Brucella abortus. It is usually transmitted from the animals to man through a milk product or uncooked meat. So very important, brucellosis is caused by Brucella. It can be abortus or it can be militensis, and it is transmitted through the milk products or uncooked meat. A variety of constitutional or ocular features, 20% are reported, the later including chronic anterior and posterior uveitis, papilledema, and retinal hemorrhage. So, anterior and posterior uveitis can also occur in it. There can be papilledema, retinal hemorrhage. Investigation should include serology and blood culture. Treatment is combination of two antibiotics, for example, streptomycin and doxycycline with adjuvant steroids if required. So you have to give two antibiotics, streptomycin and doxy, in this case ST. In the case of a brucellosis, and we can also give adjuvant steroid with it. Patient with known brucellosis should undergo ophthalmic examination. Endogenous bacterial endophthalmitis. Introduction. Rot spot develop in about 1% of the cases of bacteremia, but no frank ocular infection occur in a great majority of the cases. So, uh, rot spot are basically the hemorrhage on the retina uh, that occur in a case of a bacteremia or when there is a bacterial infection in the blood, but usually no frank ocular infection occur. A wide range of organism can be responsible. Gram positive predominant in North America and Europe, and gram negative in Eastern Asian. So in Asian they are going to be gram negatives that going to affect the eye, and in Europe and North America gram positive. Risk factors included debilitating disease of many types as well as factors such as intravenous drug abuse. Spread can occur from any potential focus such as indwelling a catheter or septic joint. So if the spread can occur, it can occur from the catheter or septic joint. Patients are usually systemically unwell and mortality is relatively high, 5 to 10%. The prognosis is poorer than in post-operative endophthalmitis. So prognosis is very poor in a case of a endogenous bacterial endophthalmitis. Ocular features diagnosis is frequently delayed. The main distinction is from the endogenous fungal endoph because it is more common than a bacterial endophthalmitis. Symptoms are the blurred vision, pain, and redness. Signs are broadly similar to post-operative endophthalmitis. So you can see AC reaction, hypopyon. They're going to be the vitritis as well. Though retinal infiltrates may be an early feature reflecting the root of infection. So you can see 12.71. So there are retinal infiltrates, which are the whitish lesion that are present on the retina. So it is so showing that the endogenous root is there. Investigation: the search for septic focus, blood and urine cultures, septic arthritis, endocarditis, lumbar puncture should be in collaboration with an appropriate physician and involved research. Aqueous and vitreous samples should be taken for microscopy and culture. Treatment is with the systemic infection is treated with intravenous antibiotics according to the clinical suspicion and local microbiological advice. Broad-spectrum empirical treatment may be necessary. So you have to treat the systemic infections, and for that you need a systemic antibiotics. For endophthalmitis is treated with intravitreal and oral fluoroquinolone. The place of systemic steroid is undefined. Pars plana vitrectomy may improve the prognosis in some patients. So for the endophthalmitis, you can give intravitreal antibiotics, and also you can give the oral fluoroquinolone with it. Then a cat scratch disease. Cat scratch disease, which is known as Bartonellosis, is caused by Bartonella henselae, a gram-negative rod. So it is a gram-negative rod. Infection is usually mediated, transmitted by the scratch or bite of an apparently healthy cat, though feline contact is not always described. So cat scratch is usually caused by the scratching of a cat. even by the healthy cat. One or more red papules at the site of inoculation are followed by fever and regional lymphadenopathy. So when a cat scratch, you can find that there is going to be the red papule at the site, and after that there are going to be the fever and lymphadenopathy. The journal symptoms are frequently absent. So where systemic disease occasionally occurs, the visual prognosis is usually reasonable. So 12.72 is showing cat scratch disease, a ulcerated papule on the cheek caused by a cat scratch 2 weeks previously with enlargement of the submandibular lymph nodes. So you can see that there is some enlargement here and there is a scratching of hair. Ocular features, the eyes are affected in 5 to 10%. Neuroretinitis is the most common manifestation and consists of disc edema with macular exudate in a star conformation. So neuroretinitis basically involves the neuronal component and the retina as well. So they're going to be the macular star conformation and going to be the disc edema. Intermediate uveitis, focal retinochoroiditis, vasculitis, and rarely an optic nerve head angiomatous lesions have been reported. Conjunctivitis with 2 to 4 conjunctival granuloma and associated preauricular lymphadenopathy. Perinode ocular granular syndrome may occasionally be seen. It is unusual for both eyes to be involved. So there is a condition we have studied in the conjunctivitis known as perinode ocular granular syndrome, and it is basically a conjunctival granuloma and preauricular lymphadenopathy. Investigations include serology of the Bartonella henselae. Uh, Treatment is doxycycline 100 mg twice daily for 4 to 6 weeks, should be used in immunocompetent adults. Oral erythromycin should be used in children. So basically the treatment of choice is oral doxycycline 100 mg for PD for 4 to 6 weeks, and you can also give it in the after in the children in the children you can give oral erythromycin. Other oral antibiotics, for example chlortrimoxazole, azithromycin, rifampicin, or ciprofloxacin are affected. Steroids have been used in some cases. Treatment is not usually given for mild systemic symptoms alone. Leprosy. Leprosy or Hansen disease is a chronic granulomatous infection caused by the Mycobacterium leprae and Mycobacterium lepromatosis. So leprosy is basically caused by, like, a tuberculosis is caused by Mycobacterium, but it is a leprae. The mode of spread remain uncertain, though nasal secretions have been implicated. Infection is thought to lead to a chronic immune response that leads to a peripheral neuropathy that is primarily pathogenetic mechanism. So there is going to be the neuropathy in a case of a leprosy, and there is going to be the decreased sensations in the nerves that is causing the problems. Genetic factors are probably important. Only 5% of the general population is thought to be vulnerable to leprosy on substantial contact with the organism. So systemic features, so there are types of leprosy. There can be tuberculoid, paucibacillary in WHO classification. There is borderline, which is multibacillary. Then there is a lepromatous, which is also the multibacillary. So we can divide it into a paucibacillary and multibacillary. A paucibacillary is basically a tuberculoid type. One or more hypopigmented macule and erythetic skin patches. So basically macule is an area of depigmentation without any raising or papule formation. It is just a skin color change. So there is going to be the hypopigmented macule and with the anesthetized skin patch. There is multibacillary, the most common form, similar to tuberculoid, but it is more numerous and extensive lesion. So the borderline is having a more lesions than that of a tuberculoid. Lepromatous, which is a multibacillary, widespread cutaneous thickening with leonal facial experience. So when there is a facial experience like leonine, you can see 12.73a, the patient is having a leonine facies, peripheral plaques and nodules, upper respiratory tract involvement, peripheral nerve lesions facilitating trauma that may result in the shortening and the loss of digits, because there is no like nerves are not working properly. So if there is a trauma, you don't know, and there is a result in shortening and loss of digit. Next is ocular features in the case of leprosy. Ocular signs are particularly due to direct bacterial infection, keratitis, thickened beaded corneal nerves, punctate subepithelial lesion, painus, and vascularization. So, prominent corneal nerve is also the feature of leprosy. And there is a prominent corneal nerve, there can be the subepithelial punctate lesions, there can be painus and vascularization. So, like this, A is showing corneal involvement with painus, B is showing lepromatous chronic anterior uveitis with meiosis, and C is showing iris pearls. Anterior uveitis chronic and low grade is classically described as plasmoid prominent fibron. Meiosis and iris atrophy result from impaired dilated pupillary innervation. Iris pearls is basically pathognomic, usually under 0.5 millimeter in diameter. Other features include episcleritis, scleritis, retinal pearl, uveal effusion, cataract, glaucoma, decreased corneal sensation, facial nerve palsy, eyelid deformities, and phthisis bulbi. So these can all be the part of a leprosy. Skin and investigation, skin and occasionally ocular specimen show acid fast, especially the lepromin test distinguishing between the tuberculoid and lepromatous leprosy. Treatment: systemic combination regime of extended duration with antibiotics such as dapsone, rifampicin, and clofazimine. BCG vaccination offers some protection. So basically, it includes dapsone, rifampicin, and clofazimine as a treatment for the leprosy. Ocular anterior uveitis is treated with steroid. Specific complications are addressed as indicated. So other complications are treated as necessary. So that's it for the uveitis part 14. See you in the next lecture.